Yeah, so for the next session, the roundtable discussion, I'm glad to welcome Professor Judy Bahous, Professor of Chest Diseases, to moderate this interesting roundtable discussion regarding the lessons learned and the implementation of this lesson on the healthcare future in both countries, in Egypt and Lebanon. I have our esteemed guests, Professor Adel Khattab, Professor of Chest Diseases, Professor Yasser Mustafa, Professor and Head of the Department of Chest Diseases at Ain Shams University. We are honored also by the presence of Professor Musa Riyashi and Professor Zainuddin. Please, Professor Judy.
Good morning, everybody. Yes, I want to really thank the organizer for this beautiful idea of collaboration between the two societies. And I hope that the new generation will be able to revive the Arab Thoracic Society and to make this collaboration wide. So we'll start our round table. First, the round table is divided in every panelist will talk 5 minutes, and then we will keep 20 minutes for discussion between the panelists and also any comment or question from the audience. So let's start with our colleague, Professor Yasser Mustafa. Professor Yasser Mustafa is going to discuss the challenge we meet with the diagnosis of COVID-19. Is Dr. Professor Yasser available?
Good morning.
Good morning. So what I want to ask you first is PCR is really necessary in every patient, and how can we help to have a diagnosis beside the fact of doing PCR? Is CT chest could be of any help? Please.
I want to thank you and thank your colleagues from the Lebanese Chest Society to cooperate with us. Inshallah, in the near future, will be with us physically. Bismillah. Definitely, diagnosis of COVID is a dilemma, and in clinical practice and actual practice, usually we depend on many investigations. PCR, as it is the golden standard in diagnosis and the only surest way to tell that this is a positive case, but still, as a test, it has a very, not very low, but a considerable low sensitivity. As we know that more than 30% of cases may be negative and they are definitely positive. That's why during practice, in the beginning of the era of COVID-19, we noticed that there is a specific and a typical changes in the CT, which proved to be maybe more sensitive than the PCR, maybe up to 90% or more. It has a characteristic shape in the CT, and all our colleagues in this field used to diagnose it through the CT very easily. And as you know, according to the radiological classification, we have RADs from 1 to 5, 6 if it is confirmed, according to the distribution of the patches and the bilaterality of the patches. We consider our patients accordingly or classify them from 1 to 5. That's why CT in practice, besides the clinical history, history of contact, history of classical presentation, which usually or lately upgraded into some other manifestations like diarrhea, like skin rash, like anosmia. If we have such clinical presentation, usually with fever, which is present in more than 85% of cases, in the presence of CT criteria, typically for COVID, usually we can diagnose without PCR or even with negative PCR. This is besides the lab. The lab is also very important, as we noticed that there is some characteristic labs, but we can't depend on the lab alone because the changes which happen in the lab, like increased inflammatory markers, ferritin, D-dimer, ALT, and even lymphopenia. Although it is something strange with COVID, usually we know that viral infection causes lymphocytosis and monocytosis in some cases, but the characteristic lymphopenia, if present, it may direct our concern about COVID. I think it is something like a puzzle. We have to put the squares beside each other. So if we have a clinical characteristics of COVID in the presence of increase in the inflammatory markers with or without lymphopenia, in the presence of the classical and the typical changes of COVID, now we can tell that this patient is COVID, and this is actually what happens in our practice, even if we find PCR negative. That's why it is a multi-modality approach for diagnosis. I think in COVID, we can't depend on a single lab or a single investigation. PCR is important maybe for epidemiological purposes in clinical researches to tell that this is confirmed case of COVID in order to experiment some drugs or something like this. But I think in clinical practice, we have to depend mainly after clinical assessment and history taking on the inflammatory markers and the CT findings, especially in developing countries with limited resources to do PCR for all people, as PCR is still expensive. There may be in the near future another investigations or another tools for detecting of the antigen is less expensive.
What is the role of the dimer? Do you think that doing the dimer will help in the diagnosis, help in the management, but that it make the diagnosis more easy or more accurate?
Definitely, D-dimer is one of the acute phase protein which is released in many inflammatory diseases. It may increase in pregnancy, it may increase in malignancy. That's why, as I mentioned, it is alone cannot be depend on it as for diagnosis. Now in practice, ordinary people used to do D-dimer alone and come to me, D-dimer is high, I have COVID even without symptoms. And this is something which is very strange. Definitely, it may be one of the markers to assess the inflammation, but in literature, when we find that there is some vascular accidents occur in patients with COVID, especially pulmonary embolism and pulmonary infarction, when we correlate this with high D-dimer observed in such patients, also with some events mentioned by our colleagues from the neurology department that some patients may have something like strokes. So there's some vascular events in the form of microthrombosis which may occur in patients with COVID. If we correlate this with the D-dimer, we may tell that D-dimer is a marker for assessing these vascular and expecting these vascular events which may happen to my patient. That's why I can give, in some situation, anticoagulation, like that mentioned by most of the guidelines in such patients. But D-dimer alone to help me in diagnosis, I think no.
Thank you. Now we're going to move to Professor Khattab, and we're going to try to find out update on the antiviral. How do you position antiviral versus corticoid?
Good morning, Dr. Bahous, Professor Bahous, Professor Zainuddin, and Professor Riashi. It's a great honor and pleasure to be with you and with my friend and colleague, Professor Mustafa. Now, the role of antiviral in different antiviral in management of COVID-19. Early during the pandemic, there was many papers regarding the use of hydroxychloroquine with or without azithromycin, and all proved that both are not effective. Till October 15, the publication of Solidarity study by the WHO, and you know, of course, this study carried on in 30 countries, 405 hospitals in 11,226 patients. The conclusion is that both remdesivir, hydroxychloroquine, leponivir, and interferon all have little or no effect in hospitalized patients, both in mortality, need of mechanical ventilation, and in the hospital stay. That's why in November 19, there was a rapid recommendation from the WHO in two issues. In remdesivir, there is weak or conditional recommendation to use remdesivir both in severe and critical inpatients because there is no effect on mortality, need of mechanical ventilation, and hospital stay. And at the same time, there is a recommendation to use corticosteroids for severe and critical patients.
Is it not a little bit, we find that two articles, one in the New England Journal, which has been published on the 5th of November in favor of using antiviral, especially remdesivir, and WHO on the 20th of November published that we should not use it. What do you think about these two contradictions about remdesivir? And maybe also the add of corticoid or non-corticoid on the antiviral may change the result?
Well, of course, there is controversy in different papers, but again, the Solidarity study, as I have mentioned, it was in a large number of patients, more than 11,000 from 30 countries. On practice, we found remdesivir still effective, but if used early or very early. If used early, the results is good, but using late, the results, there is no significant difference.
So time is a good factor. Time is an important factor. What dose of corticoid you use? Are you using in Egypt a high dose of corticoid, or when did you increase the dose of corticoid?
Well, in Egypt we have MOH published 4 protocols. The last one was in last days of November, and early the first protocol by the Egyptian MOH was issued in March this year, and they recommend the use of corticosteroids starting from the moderate patients. We use also inside, for hospitalized patients, the severe and the critical. Sometimes for the moderate, we use something between 20 and 40 milligrams prednisolone daily. It depends on the case, but of course, for hospitalized patients, we use IV methyl prednisolone.
High dose, or only for, do you increase the dose to 80 and to 125 BID, or you don't use it this approach?
We use 125 to 250 every 8 hours, depending on the case. But let me add you for the Egyptian experience. Now, we depend also in 2 drugs, the combination of sofosbuvir and daclitavir used before for treatment of virus C for the mild and moderate cases, and it showed good results. And another drug which approved by the FDA in vitro, which is ivermectin. We use it here because it is in the last version of the Egyptian MOH protocol. You know, of course, ivermectin is a drug for anti-helmintic, but it is suppress the replication of the coronavirus, and this is approved in vitro by the FDA. And here in Egypt, we have many studies on that, and one of our studies for our colleagues in Banha and Catholic University, and now it's under publication by Nature, prove the efficacy of ivermectin not only for treatment, significant result compared by hydroxychloroquine, but also in prophylaxis.
Thank you, Professor Khattab. Now going to move to Professor Salah Zainuddin. Salah is going to a little bit tackle the issue of antibody and plasma, mainly plasma transfusion, its role and advantage and inconvenience. Dr. Salah, how many times and how frequently have you used an AUB plasma transfusion?
Hello, everyone. Hello, Judy, and all the friends in Egypt and colleagues. We have been pretty much using the convalescent plasma transfusion frequently. Now, as we know, the data is a little bit unclear in some extent. There are still evidence to support the possibility of its benefit. I'm going to discuss this in a moment. So in AUB, we've been using it pretty frequently, especially for patients who do have pneumonia documented and a desaturation below 93% on room air, who require to be admitted to the ICU and to the hospital. We're not using it for mild cases, but we're using it for moderate cases or severe cases or life-threatening cases. The frequency is we're using 2 transfusions 1 day apart within 24 hours, each about 200 to 250 ml. And our experience has been enlarging. I think we've used it already at least for 300 plus patients over the past couple of months.
Do you think the response is depending on the importance of the antibody level in the plasma? Do you measure antibody level before transfusing it?
We're measuring the antibody levels for the donors, but not for the recipients, of course.
Yeah, but
the issue with that is we are trying to start it as early as possible, which supposedly they did not have time to mount their own response at that time. Data have been showing that if you try to transfuse within the first few days, the benefit may be more evident. And also, if you look at the data, especially the last controversial outcome paper, everybody I think is going to be talking about in the New England Journal of Medicine, that using the convalescent plasma is not helpful, or it's a negative study. But really, if you look at the other data, those sporadic information, and about the JAMA paper, which was out in August, we see that there is a subset of patients who are the severe cases, but not the life-threatening one, which may be speaking of an early intervention before it gets to a very, very severe life-threatening. If transfused with plasma, there is a trend, and I say not statistical significance because of the number of patients, towards having a positive outcome and shortening the stay and turning into a seronegative state faster than the people that did not receive plasma.
My question is the donor, the level of antibody in the donor would affect the result? I mean, if the donor has more IgG than another one,
yes,
is plasma more effective?
Excellent question. To be honest, Judy, we don't have this data yet, but we're looking at it because at the moment we're just testing donors who do have positive IgGs and collecting from them. And we're actually looking at our data if the level of the donor pre-collection would correlate with an outcome. But so far, we don't have this data out yet.
Okay. Did you have any reaction called antibody-dependent enhancement? You see, the risk with this is that if you use it at maybe too early, that you will enhance the viral, and this, then you will get more serious reaction?
We have not seen that yet, but again, the data, excuse me, I'm recovering myself from COVID. So the issue is we're also looking at this if transfused very early versus having the syndrome already, which is kind of not too early, but also not late, will have an outcome. Data is not out yet, but as you know, we're just trying like everybody else.
What about hyperimmune globulin? Did you think about it? Did you plan to use hyperimmune globulin?
By definition, if we believe that the plasma should be somehow helpful, hyperimmune globulins maybe are, but we have not been using it so far. We have not tried it, and but this is something we're contemplating.
May I ask one question, Dr. Bahous Salah?
I think we'll keep it. Okay, go ahead, George. But
yeah, no, just because I think one of the important elements that all the panelists should address is, what do we mean by early? Early what? Early viral infection, early replication? Do we have any idea when the patient or the person gets infected? Because that may be totally different than when they present to healthcare. And this is a major issue related to when you start antivirals, when you check the immunoglobulin levels, when to decide on convalescent plasma, the steroid dose, other antivirals, etc. So this is, I think, to me, a black box, because I don't know if we have any probe that can tell us exactly how much viral activity we have and the timing between initiation and the presentation to care.
Correct. Just to answer quickly, George, for the sake of time, Judy, بعد إذنك. Definitely the issue of early is unclear, but most people now, when they are tackling the intervention, they're talking about within 24 hours of the clinical deterioration and the hypoxemia. But that is not solid enough. For example, the early paper in 2005, which was very solid about the benefit of convalescent plasma in SARS-1 in Hong Kong, okay, was talking about early as in the first 14 days of the illness. Okay, and that showed a very good positive signs at the time. But now with the COVID-2, the one we're dealing with, it's unclear, and mostly we're talking about within 24 hours of the clinical deterioration of the development of hypoxia.
Thank you, Dr. Salah. For the sake of time, we're not going to talk about monoclonal antibody. It might be in the discussion. Now we're going to move to our dear friend Musa. Dr. Musa Reishi is going to talk about the very sick patient who are going to be in need of different oxygenation. How do you approach this very heterogeneous hypoxemia in COVID patient, Dr. Musa? مش عم نسمعك موسى. ما عم نسمع موسى.
Good morning, everyone. Yes. Good morning. Thank you for your question. Hello, everyone. It's really important. The heterogeneous hypoxemia is really a big problem in COVID patients. And as you know, we understand a lot about the disease the last months, dependent on the phase of the disease. If we are having patients in the initial phase where there is a lot of virus, it's due to pneumonia, due to virus. But in the second stage, it will be due to the inflammation, and it's not due to the virus by itself. And third, we know very well that in this disease, we have a lot of patients with the vascular problem. It can be a shunt or it can be a thromboembolic events. So the likelihood of hypoxemia for this 15–20% that will have lung involvement will be totally different depending on which stage we are approaching the patients. So it's very important to keep this in mind, and to keep in mind that there is a clear discrepancy between dyspnea and hypoxemia. So we should not rely on the patients when he is dyspneic to search about hypoxemia, and this is major. So what I can say, the first insult of the lung will be a kind of silent hypoxemia, or we can call it happy hypoxemia. It should be searched, and we understand a lot in the last months. It's due to what? Most probably it's due to the shunt from the right to the left heart, and this can induce hypocapnia that has a big breakdown to the respiratory center. The second explanation of this discrepancy and the hypoxemia is the high level of density of ACE2 receptors in the carotid bodies, and that's why the centers are not anymore aware about the level of oxygen in the blood. So it's very important. We should search for it to find it and treat it early.
Do you have any criteria when to intubate? Do you use a score, any score to say, yes, we will go for intubation early, we don't want to do it during midnight? Nobody is there specifically that we have to take a special precaution?
Yes, sure. Before deciding to intubation, we decide to assure the oxygen needs of the patients. And to assure the oxygen level in the hospital, we rely, if the level is so low, to the nasal cannula till 6 liters. If we need more than 6 liters per minute, we have two choices: the non-rebreathing mask and the high-flow nasal cannula. For the non-rebreathing mask, we are using it a lot on the floor, but we should keep in mind what was documented recently, that we should not rely on the leaflet coming with these non-breather masks. I mean, when we put 10 liters per minute, for example, with non-breathing masks, we are not assuring a very high percentage of FiO2. So if we need to have a good way, we should use the formula of 3%. If we are using the high flow oxygen that we are using a lot these last weeks, it's very important to know that this can assure a high level of oxygen, well humidified, a small level of PEEP, and it can decrease the dead space and the work of breathing. So we are relying a lot in the last months on these devices and to try to evict intubation. Once you arrive to decide for intubation, to respond for your question, it's very important. In the beginning, we were pushed to intubate early patients. Why? Trying to have contagious patients and to stop the risk for the healthcare provider. And patients arrived lately with a severe hypoxemia. So we were intubated the patients early. Then came the Tobin reflection that it was documented for ventilated patients, they will pass more days being ventilated, so more complication. So they suggest it can be not a good idea to intubate very early. What's important nowadays in December 2020 is if we want to delay a little bit the intubation, we should measure the respiratory drive. Why? Because 50 to 60% of our patients coming to the intensive care approaching the intubation, if ever they have a high respiratory drive, they will have a high tidal volume, they will have a patient self-induced lung edema, and they will aggravate their lung function if we delay the intubation. So for this group, we need, and we still need, not to delay the intubation.
Are you using prone position for the patient?
Yes, we are trying to use the criteria, the PROSEVA criteria that we use normally for ERDS. So each time we have a patient who has optimized ventilation, we still have the PO2 over FeO2 less than 150. We are putting him on 16 hours period of prone ventilation per day.
Thank you, Professor Musa. Now I don't know, the chairman, do we have still time to go into some discussion between panelists, or we are over?
I think we can have two short questions with two short answers, one from your side and one from our side.
Now we are one side, Hakim. Okay. Anybody, Dr. Musa, Dr. Salah, do you want to ask any question for our dear colleague from Egypt?
Yes, I have a question. In fact, do you have any experience with tocilizumab, anti-IL-6, and what was your outcome?
Definitely we have experience with this drug. We used it a lot before. The problem is in the price and the availability, which is not constant all the time. But again, if it is used early in the beginning of the cytokine storm and the beginning of the inflammation of the which happened due to the viral infection, it is effective. But if we use it late, usually it has no effect.
To go on this subject again, you know that IL-6 is increased in many inflammatory disease, and we have been using monoclonal, or try to use it in all disease, any adult respiratory syndrome, and the response was not good. Why it should be good with COVID? The question is there. Therefore, they're very controversial. What is your opinion, please?
Definitely, when inflammatory markers mentioned in the COVID, it was mentioned interleukin-1, 6, and others, but because it was available at that time in the market, the monoclonal antibody for interleukin-6, which was used before in treatment of some collagen disease, I think this was something like experimental, because at that time we have no available weapons. So anything which may be beneficial, it will be used definitely until it is well studied after that. And it is still controversial. Actemra or tocilizumab is still controversial. We find some people say that it's effective and others say it is not effective. But in our experience, definitely when we use it early, usually it is effective. This is just a clinical observation. But when we introduce the measurement of interleukin-6, we have now interleukin-6, we can say, we can measure it in the serum of patients. We find that most of the patients have high interleukin-6. But the issue is that, as you mentioned, Professor Bahous, is that it is not interleukin-6 alone, the inflammatory marker. We have many, many inflammations. That's why in some people, in some patients, when they receive the anti-interleukin-6, we don't say, because there is definitely another interleukin which may have a role in such.
Last comment or question.
I have a question. Looking at the numbers or the figures, we find that the registered case in Egypt yesterday was about 116,000 plus. Maybe it's the same number registered in Lebanon. Mind you, the population here in Egypt is 100 million. And another thing is the mortality. You register the mortality about 0.8%, something like that, while the mortality in Egypt is much higher. Maybe it's about 6%. I want to know your policy, both in registration and in reaching that very good mortality.
Salah, if I can start, if you can permit. I think, first of all, we have too many centers actually that are trying to test more and more patients. That's why we have a lot of patients per day, depending compared to the first months of the disease. Second, the medical system is not yet overwhelmed. So we are still succeeding to apply our protocol, to modify our protocol, and to assure the need of our patients. This cannot be for a long period. Why? Because we are on pressure from authorities and from administration to increase our, for example, ICU bed. But as we all know, ICU bed is not a bed and a ventilator. It necessitates times, it necessitates to have teams and necessitates specialists. So this specialty cannot be afforded in weeks and in months. So I am afraid what we are succeeding to do till now will not persist on the long run. And it's very important to know how to prevent the disease and to prevent the arrival of the patients to the hospital or even to the ICU. So I think till now the numbers are so low in mortality because the system can arrive to handle the severe cases till now in all the hospitals. Thank you.
And if I get a chance to also make a small comment on that, Dr. Khattab, I believe as well the difference relates to the screening vigilance. I think we're based on having 4 million people with about 100,000 cases versus 100 million with 100,000 cases at the same time. I think it relates to screening, and this is why maybe we are having a higher ability of detection because we're screening with a much lower threshold than what's happening in Egypt. So by that fact, we're having a more detection of cases, which will eventually lower the mortality. Maybe if you have a higher vigilance of screening in Egypt, you'll have like 600,000 cases identified, and then you will have still almost the 1% mortality we're having in Lebanon. That's what I believe in. If I may finish with a question to you, Professor Khattab, as well. I think one of the attendees have a similar question, is about the dose of ivermectin used. Because the dose of ivermectin mostly used in vitro was about 10 to 100 times more than the physiologic doses used. How are you approaching that?
We use ivermectin both in prophylaxis and in treatment. For prophylaxis, the tablet is 6 milligrams. We use for prophylaxis 4 tablets before lunch, and then you can repeat the dose after a week. This is for prophylaxis, and in the paper under publication from our colleagues, it gives a good result for the healthcare work. For the treatment, there is 2 different regimens. The regimen in the paper I have mentioned under publication in the Nature, they used 4 tablets again, that's 24 milligrams, before lunch, and repeat this dose for 4 successive days. But in the protocol of the MOH, they used 6 tablets daily, and first day or day 0, and they repeated day 3, day 6, and day 9. Of course, I know it is little than the recommended dose, but for the maybe GIT and the tolerance of the patient, but this dose was by the trial is effective. Let me comment on your comment about the numbers, because we have a study mentioned that the population registered in Egypt, those diagnosed COVID in Egypt by the PCR, only 15%. Mind you that not all the 15% have gone for the PCR, did that in MOH hospitals or centers. In Egypt, the private sector is very wide. That's why the registry is low.
Thank you, everybody. Again, I want to thank all the panelists and definitely the organizer for very interesting meeting, and hope for a collaboration at all levels. Thank you and good luck.
Thank you so much, and we hope to see you next time, either here in Cairo or in Beirut face to face. Thank you.
Hello, thank you very much.
Thank you.
Take care.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.